So we have presented the IFM 2017-03 trial at ASH this year. So it's a trial, phase 3 trial dedicated to frail population of patients with a dexamethasone sparing strategy. So the trial is randomizing elderly patients with newly diagnosed multiple myeloma who are frail per the ECOG proxy frailty score. And the patients were randomized to receive either daratumumab, lenalidomide, with only 2 cycles of dexamethasone, and then stop dexamethasone versus the previous standard of care treatments of lenalidomide and dexamethasone. Both arms were given until progression, and the primary endpoint was PFS. Yeah, so we have included a population of frail patients, and I think we can say that it's the first phase 3 trial for elderly frail patients. So the median age was 81 years old. 2/3 of the patients were above the age of 80. Half of the patients had ECOG of 2 or more. So we have reported the PFS, and we observe significant benefits of median PFS in the DR arm, so daratumumab lenalidomide. So the median is 53.4 months versus the lenalidomide dexamethasone group of 22.5 months. So this is a hazard ratio of 0.51 and a significant p-value. And we also observed an improvement of overall survival in the population. So the median was not reached in the DR group, and the median was 47.2 months in the Lendex group, with a hazard ratio of 0.52 and a significant p-value. And the last point we studied is the safety of the 2 different regimens. So the one daratumumab lenalidomide with the dexamethasone sparing strategy, and lenalidomide dexamethasone. And what's interesting is, despite the fact that patients in the DR group received the treatment much longer, they had some increase of grade 3/4 side effect, but this was mostly the hematological side effect and actually the neutropenia that was higher in DR versus Lendex, but there was no increase of grade 3/4 non-hematological side effects and no increase of infection when we add daratumumab. So it was 19% of grade 3/4 infection in the DR group versus 21% in the Lendex group, and there was no increase of treatment discontinuation in the DR group versus the Lendex group. So in total, we think that, the treatments with DR and this dexamethasone sparing strategy is obviously more efficacious in terms of PFS, overall survival, and so as well tolerated without this increase of non-hematological side effect or infection that we usually observe in other trials with frail patients. So I think that we are now dividing the population of elderly patients with diagnosed multiple myeloma in 2 different groups: the patients who are fit and the patients who are frail. And for this, so the patients who are fit will be able to receive more intense treatments, like the quad, for example, regimens. But for the frail population of patients, I think this strategy of dexamethasone sparing regimens is relevant, because we see in this truly frail population of patients a very good efficacy with the 53 months of median PFS, and the profile of toxicity is, I think, very good without increase infection rates, for instance. So the quality of life of the patient, I think, is very good with this dexamethasone sparing regimen. So it could become a new standard of treatment for the elderly frail patients with newly diagnosed multiple myeloma.